So, good afternoon, everyone. Hope you all are doing well. Today, we are going to discuss a case-based approach to an adrenal incidentaloma, a very commonly encountered scenario in our clinical practice, and of course, from exam perspective as well. Today, we are going to cover the European Society of Endocrinology Guidelines 2016, as well as was there an interesting journal article in Endocrine Society Review in 2020. Which was published regarding the approach and the management of adrenal incidentaloma. We are going to cover both of them via case-based approaches. So let's start right away. So what do we define as an adrenal incidentaloma? It is a mass lesion which is greater than 1 centimeters in diameter, discovered incidentally during radiological examination. So that's straightforward, but it should be more than 1 centimeters in diameter. What are the commonly encountered adrenal incidentalomas? First, we are going to look at what are the lesions for unilateral adrenal masses. If you look at endocrine inactive or non-functional adrenal adenomas, they account to almost 60 to 85% of all the adrenal incidentalomas. So that is the most commonest, non-functioning or endocrine inactive. Cortisol producing, which accounts for Cushing's, is around 5 to 10%. Aldosterone producing, which accounts for Cons, is around 2 to 5%. Pheochromocytoma, 5 to 10%. And then there are other rare lesions like cyst, myelopoma, or hemangiomas. In terms of malignancy, adrenocortical carcinoma accounts for around 2 to 5%. Malignant pheochromocytoma is less than 1, and metastasis most frequently from breast and lung cancer, which can travel to the adrenals, that can account to around 1 to 2%. What about bilateral adrenal enlargement or masses that can be caused by congenital adrenal hyperplasia, bilateral macronodular hyperplasia, bilateral hemorrhage due to antiphospholipid syndrome, or sepsis-associated Waterhouse-Friderichsen syndrome as a part of meningococcal sepsis, granuloma, amyloidosis, or infiltrative disease, including tuberculosis. So what are the questions which we should think of when we are encountering an adrenal incidentaloma? First, are there any clinical features suggestive of possible diagnosis? Here we are thinking about functional adenomas like cortisol producing. So if there are features of Cushing syndrome, like drastic weight gain, myopathy, there is worsening of diabetes or hypertension, young patient onset of osteoporosis, even for that matter, facial plethora and buffalo hump, and also in terms of purple stripe. So all these clinical features which we are going to look for to find out if there is a possibility of a functional or a cortisol producing adenoma. Secondly, when we are talking about pheochromocytoma or paraganglioma, are we getting any classical triad of sweating, palpitations, paroxysmal hypertension, all of which can make us look for a possible functional pheochromocytoma. Then we are talking about Cons syndrome or aldosterone secreting adenoma. We should think and find out if there is any history of spontaneous hypokalemia, previous diagnosis of hypokalemia and hypertension. All this can make us think of a possible diagnosis of Cons adenoma. And then we are talking about malignancy, of course. We saw that that accounts to around 1 to 2%. So such patients may present with fever, weight loss, other systemic symptoms as well. And there can be systemic manifestations of other primary malignancy with metastasis to the adrenals, like I mentioned about the breast and the lung cancer as well. The second question which we should ask is it benign or is it malignant? So this is the second question which we should ask. And this is what we are going to look in the next slides. And the third, is it functioning? So we already looked for the clinical features, but also is it functioning means we are trying to look for any biochemical abnormalities which we can detect to see if it's a functional tumor or not. So for the second question which I mentioned, is it benign or malignant? So what are the imaging characteristics? We'll be going in detail with that in the next subsequent slides. But what are the imaging characteristics of a benign or a malignant lesion. So a homogeneous adrenal mass less than 4 cm in diameter with a smooth border and less than 10 ounce per unit attenuation value on an unenhanced CT scan, and a rapid contrast medium washout of more than 50% in 10 minutes is very likely to be a benign cortical adenoma. What are the features suggestive of adrenal carcinoma or metastasis? Irregular shape, inhomogeneous density, high unenhanced CT attenuation value of more than 20 Hz per units, a delayed contrast washout of less than 50% at 10 minutes, diameter of more than 4 centimeters, and tumor calcification. What about FIOs? FIOs should always be excluded in all patients with adrenal incidentalomas, and they will classically have a Hausfeld unit of more than 10. We need to rule out a pheochromocytoma by biochemistry and by doing a 24-hour urinary fractionated metanephrine or a plasma fractionated metanephrine. So if we talk about imaging, as I mentioned, unenhanced CT is the procedure of choice for imaging of the adrenal glands. MRI, as it is not involving exposure to ionizing radiation, is preferred in children, young adults, and during pregnancy. MRI has just a valuable role in characterization of intermediate adrenal lesions using chemical shift analysis, with malignant tumors rarely showing loss of signal on a post-phase MRI. Now, this is more in detail about the specific characteristics which we'll see for benign malignant lesions and also for metastatic lesions. We already discussed that in that slide. I'll quickly go through this as well. So as I mentioned, for benign looking adenomas, the imaging characteristics will be less than 4. So very important, all of them for exam. That's why I just repeated them in these slides. A contrast washout of more than 50% at 10 minutes. Chemical shift evidence of lipid on MRI. Usually unilateral location, round and homogeneous density, smooth contour, and sharp margination. Typical features suggestive of FIO definitely be more than 10 HU. In many cases, it is usually more than 20 HU, like a malignancy. But of course, we'll have a biochemical evidence of FIO as well. There'll be increased mass vascularity, which we can encounter in FIO. On imaging characteristics, there will be delay in contrast washout, usually less than 50%, like how it happens for malignancy. There'll be high signal intensity on T2 weighted MRI. There'll be cystic and hemorrhagic changes possible, and there can be a variability in the size, and they can also be bilateral. About adrenocortical cancers, and as I mentioned, irregular shapes, inhomogeneous densities, tumor calcification, diameter more than 4 cm, unilateral location, usually CT attenuation value of more than 20 on an enhanced CT scan, delayed contrast washout of less than 50% at 10 minutes. There will be hypo-intensity compared with liver on T1 weighted MRI and high to intermediate signal intensity on T2 weighted MRI. There will be a high standardized uptake value, we call it SUV, on FDG PET CT study. And there can be evidence of local invasion or metastasis. Metastasis also will be irregular shape. They can be bilateral. Definitely, they will have a CT attenuation value of unenhanced more than 20. There will be delay in contrast washout. There will also be elevated SUV on FDG PET scan. So all these are typical imaging features of adrenal metastasis. So by all those slides, we covered the imaging characteristics of benign versus malignant lesions. Now the question, are they functioning? We already looked at the clinical features. Now what biochemical test we need to do to find out if this adenoma is functioning or not? Subclinical glucocorticoid secretory autonomy, also referred to as subclinical Cushing's, can happen, and that's why we need to do overnight dexamethasone suppression test. We give 1 milligram dexamethasone at midnight, and we measure the cortisol in the morning. That should be suppressed to less than 50 nanomole per liter. If it is not suppressed, then if we are having a value, for example, of around 51 to 138, then that can be considered as possible autonomous cortisol secretion. If the value is clearly more than 138 nanomole per liter, then this should be taken of evidence of autonomous cortisol secretion. So subclinical Cushing syndrome is now called ACS, also referred to as autonomous cortisol secretion. Of course, can do a further confirmatory test by doing a 24-hour urinary free cortisol. We do an ACTH concentration as well, which will be suppressed if the cause is adrenal Cushing's. Despite the absence of florid signs and symptoms, autonomous cortisol secretion in patients with adrenal incidentaloma has been associated with hypertension, insulin resistance, type 2 diabetes, obesity, metabolic syndrome, and increased mortality. So we cannot ignore this aspect as well of Cushing's. Subclinical Cushing's, also now called as autonomous cortisol secretion or ACS. FIOs, as I mentioned, they will definitely have an unenhanced CT of more than 10, more than 20 usually, as I mentioned in the previous slides. We need to do a plasma fractionated metanephrine or a 24-hour urinary fractionated metanephrine, which is the test of choices. If you're suspecting cons, then we have a patient who is hypertensive and hypokalemia or has spontaneous hypokalemia for that matter. So these are the patients which we will evaluate for cons. We need to do a plasma aldosterone renin, do the aldosterone renin ratio, and that's how we screen for primary hyperaldosteronism or primary aldosteronism or Cons syndrome. Now let's look at some cases. So case one, we have a 50-year-old man who's incidentally detected to have 2.5 centimeters left adrenal homogeneous mass with well-defined borders on the CT of the abdomen, which was done to evaluate his symptoms of dyspepsia. Blood pressure wise, he has blood pressure of 134/70, BMI of 32. The rest of his general and physical and systemic examination is under. Which of the following is the most appropriate next step for management? So here we have an incidentaloma or an adrenal incidentaloma. Doesn't look clinically that he has any features, but what are the most appropriate next step which we need to do in this management? Should we do a dexamethasone suppression test and urinary metanephrines? Should we directly go for an MIBG scan, MRI adrenals, serum aldosterone renin ratio, or surgical referral? So if we look at, so the free view of this particular lecture has ended. For access to this full lecture session, please subscribe to my lecture series, which is total of 60 lectures till date. These will be provided access to via paid subscription plan, and all the paid subscribers will be given a lifetime access to all my existing 60 videos lectures, which are already on the YouTube channel, plus all the upcoming new videos. So whatever lectures or sessions I'll be doing in coming weeks, months, and years, all of them will be given access to in the same subscription plan. So for the full subscription details, please email me on mazirules@gmail.com or WhatsApp me on 009715574344794 and have the same number on the Telegram app as well. Just to give a brief overview of the full lecture series, so it includes different topics across diabetes and endocrinology. For diabetes itself is around 19 lectures which I've done across different topics which are useful for the exams as well as for the clinical endocrinology practice. In terms of high yield topics for specialty exam and European board exam, there are around 9 sessions which have covered all the previous exam recalls as well as all the high yield topics and themes which are frequently encountered in the specialty exams and the European board exams. In terms of thyroid, apart from the thyroid cancer guidelines, which were recently published, plus there are other sessions on different topics related to thyroid across the spectrum of thyroid disease. In terms of adrenal as well, covering all the important topics or sessions which are frequently encountered in exams and in clinical practice. There are 2 very good sessions on lab endocrinology by Dr. Velmurugan, very helpful for those preparing for DM Endo or DNB endocrinology as well. In terms of pituitary also have covered all the important sessions on all the important topics which are frequently encountered in clinical practice and the exams. There are a few sessions on the inherited endocrine syndromes as well. Very important sessions on reproductive endocrinology, about congenital adrenal hyperplasia, gynecomastia, hirsutism, PCOS, diagnosis, evaluation, management. There is sessions on calcium and bone metabolism, on familial lipid disorders, and sessions on pediatric endocrinology as well. So just to let you know that there are many more sessions coming up, and as I mentioned, that in the same subscription plan or same subscription fee, you will be provided access to all my existing 60 lectures plus all my forthcoming lectures. So thank you very much for subscribing. Thank you very much for supporting.